diagnosing rectal cancer. Welcome.
Good morning, dear colleagues, Mr. Chairman. Thank you for this change. So, I'm going to address the problem of obstructive rectal cancer. And really, there is not a lot of literature there, and I'm going to try to give you some perspectives in how we could get a treatment algorithm. What we do know is that patients who present with an obstructive rectal cancer have an advanced disease in most cases. Quite in some patients you have T4 cancers, you have the involved margins in quite a substantial group of patients, and we all do know that they have a poor prognosis. On top of that, you have the local problems of the rectal cancer within the pelvic cavity, but you can also have symptoms of colonic obstruction. And there already there is a difference in if we quote an obstructive rectal cancer, if we then refer to the symptoms, or that we also include those patients in whom you have a big tumor in the pelvis and you cannot get the endoscope through. If you look to the broader picture, about 7 to 10% of all colorectal cancers will have obstructive disease as an initial presentation. And of those, 75% have a distal colonic obstruction, so distal of the splenic flexure. But the large majority are in the sigmoid or in the rectal sigmoid. And so it's only a minority of patients who really present with an obstructive rectal cancer. But you really can run into troubles, and here we see the clinical picture of a full-blown colonic obstruction. And it can happen in those patients, and one of the big problems is that also during the treatment, even if you avoid any surgical act and you will go for neoadjuvant treatment, that especially in those patients who have a competent ileocecal valve, that you get a progressive distension of the right colon, and you're at risk to get a cecal blowout. As you can see here, you see progressive tearing in the cecum. The problem is, once you got also involvement of the right colon, then the surgical possibilities are very limited, because at that stage you also lose the right colon, and if you then want to end up with a restorative surgery, you will end up with ileoanal pouch surgery. I start with a case that we recently had. So it's a male patient, he's young, 58 years old, he's a smoker. Since 2 weeks he had abdominal distensions, intermittent postprandial cramps and vomit also, and anal bleeding. He was found to have a tumor in the midrectum. You couldn't pass the scope. Biopsy was taken, adenocarcinoma. He hadn't any distant metastasis. And here you see the MRI of the local situation. And indeed, you only see here is the lumen, and then it's obliterated. You see big lymph nodes here. So this was staged as a CT3N2B. So then the discussion starts, how are you going to manage this patient? And what are the options? Because the patient is on the edge of having a complete bowel obstruction. You could go for urgent or resection or surgery. But then, in comparison to a sigmoid cancer, it's far more complex. You then need to do a TME with a coloanal pouch, and you have to prepare the colon on table. So you do an on-table irrigation and colonic decompression. Or you can do a low Hartman's resection. In other cases, you would say, maybe I should opt for a stenting. Then I can change as a bridge to curative surgery. Or should I put a patient on a loop colostomy? Ileostomy is not of help in those patients because you will not avoid any blowout of the colon. Or should I go immediately for neoadjuvant treatment? So you can find a lot of treatment algorithms for acute malignant large bowel obstruction, but they merely deal with colonic obstruction, with sigmoid cancer. And indeed, when you have a distal sigmoid cancer and you have an expert surgeon in home, you can do a resection on table lavage and primary anastomosis. You also can do a Hartman's procedure, a staged procedure. But it becomes far more complex when you do have a rectal cancer there. What are we going to do? Are you going to do a low Hartman's or the complexity with a TME and then a complete colonic mobilization to do a perop colonic irrigation, decompression, you then make a colon pouch and you put on an ileostomy. The low Hartman seems to be very attractive because you avoid the low anastomosis, you take out the tumor, but we do have problems with low Hartman's resections that in comparison with a high Hartman, when you do a low Hartman, we have a significant increased risk for pelvic sepsis. And you can imagine when you take out the whole rectum and you leave the pelvic cavity like that, you're going to get a complete obliteration on the long term. And the secondary restoration, the second stage of the operation, becomes a major undertaking and is not without any danger. So in most of those patients where you do a low Hartman, where you opt for a low Hartman, the patients will have a permanent stoma. And one of the problems is, and it's a frequently faced problem, is that here you see the distal stapling just above this is the coccyx at this level, and you see a huge abscess, pelvic abscess. So, and this is a quite common finding, and it's completely different when you do a high Hartman resection. This is a observational study, not randomized, but they treated patients with an intersphincteric proctectomy and compared that with 40 patients who had a low Hartman. And again, you see here, there is a significant increased risk to have a pelvic abscess, 12%, reoperation, nearly 15%, and mortality of 7%. And this is only to take out the tumor, not taking into consideration that probably you will have involved CRM also in those patients. So really a low Hartman doesn't seem to be the ideal solution. Also, when you look to the differences in mortality, and nothing has changed over time, but there is quite a big difference in doing in a semi-urgent rectal resection in comparison to an elective situation. So if we can avoid resection or surgery as an emergency or as an urgent operation, it seems to be the best. So why not do we try to get a stent in so that we have a bridge to curative surgery? And indeed, there is some logic behind it. You can change the emergency operation to an elective operation. You can optimize the patient. You look to nutrition, electrolytes. You get the decompression of the bowel. It gives you time, accurate tumor staging. If the patient has metastatic disease, you palliated him. And it gives you time to find a good team to get the cancer out. Probably you will end up with less morbidity and mortality and lower stoma rates. And indeed, you also can find some good-looking pictures. You have a tumor here. It's on the high end of the rectum, the rectal sigmoid. It now has been stented, and the lumen is again open. And at that stage, you can prepare the patients to have elective surgery after neoadjuvant treatment or after adequate bowel prep. And here you see one of a series, a Korean series, where they included sigmoid cancers and rectal cancers. They stented them, and then they looked and compared the patients who had open immediate surgery and who had, first of all, a stent and then a laparoscopic procedure. Those, again, are not randomized data. So there is certainly a bias in. You see here, quite a bit of patients had a staged operation. Again, what you see is that you cannot stent every patient. In 5 out of 30, it was unsuccessful, and they needed open surgery. Again, when you look to those figures, again, the total hospital stay was not significant, but again, they had some significant more morbidity in the open surgery. So there seems to be something in it, especially when you look to retrospective data into case series. But when you look to the prospective data, the multicenter data on stenting, then you see that there is quite some problems there. You can have perforations, not only to the guide wire, to the stent, and this has a major impact on local recurrence. And in some patients, although you can open the lumen, you have an incomplete decompression, and you end up with a clinical failure. And really, when you do, recently was a meta-analysis of the prospective randomized trials, and when you look into detail, then you see it's not that of a success story, because you see technical success rate in 70%. So in 1 in 3, the stent is not getting there. Clinical success rate is 69%. But on top of that, and this is very important, you have a clinical perforation rate of 7% and a silent perforation rate of 15%. And this, of course, will have a major impact on the ultimate oncological outcome of the patients. And 2 of the trials were prematurely stopped due to stent-related problems. And here I put it again, the French trial and the Dutch trial, the stent 2 trial. You can see that in total those are the percentages of local perforations. So the question is then whether you can use this in a potentially curable situation. And again, when you look down the pages of the meta-analysis, there was no difference in primary anastomosis, permanent stoma, in-hospital mortality, anastomotic leak, 30-day reoperation, and surgical site infection rate. And I show here the Oxford experience. When you look down the road, even when you can stent, and they looked to the local recurrence in the stented group, they had quite more local recurrence than in the non-stented group. And they stimulated that probably that you can have subclinical perforation, maybe by putting in a stent and the pressure you get tumor cell dissemination, or you can alter the pathology. And when you look, and I have got this slide from Willem Bemerman from the AMC, when you look to the stenting 2 study, that in those patients who had a perforation, you see 50–60% developed a local recurrence. So not only the risk is there, 20–30%, that you have a local perforation, but once you got a local perforation, silent or clinically, then you run into trouble on the long term. So the question is this really a bridge to elective surgery? Certainly, when you look through literature, there is conflicting results between the prospective versus the retrospective studies. We have a low technical and clinical success rate than initially thought. And again, you have disappointing high stoma rates. And probably it's not good to stent a curable fit patient. Why don't we give those patients just a colostomy? And then you gain time, you decompress the colon, and you can opt for whatever strategy you want. One of the issues is, of course, that in a distended colon, it's not always a minor undertaking to make a colostomy. It can delay radiochemotherapy, it can have several short-term complications that again will delay your further treatment. And in some patients you need to do a full laparotomy to give the patient a decent stoma. So it's logical to propose a colostomy in those patients. On the other hand, it's not always without a risk. And then to end, maybe in a majority of patients, even with complaints of obstructions, we can opt for neoadjuvant treatment. And this is the Washington University experience, recently quoted here in 2013. They had 85 patients, and again, 16 were really in full occlusion. Those patients, you need to do a staged procedure. But the other ones, 69, they did immediate neoadjuvant treatment. And only 5 of those patients had progressive symptoms of bloating distension. They could treat conservatively 2 of those 5 patients, and only 3 required a diversion. So it seems a feasible tactic in most of the patients. And again, but of course, it's not randomized, but in those who you divert, in a subset of patients, maybe they were worse on at the first issue, but again, you lose some time, and in that group of patients, they also had a significant high number that had progression to unresectable disease. How did we proceed in this patient? He got a loop colostomy on the sigmoid colon. We positioned the stoma there that he could have the radiotherapy on the belly board, so we measured that. He had a multidisciplinary consult, neoadjuvant chemoradiotherapy. He had elective surgery after 10 weeks. He had a laparoscopic TME, and this was his final pathology, and he has his loop ileostomy. So at the end, I say maybe when you have a stenosing rectal tumor, probably 9 of 10 patients can immediately start with neoadjuvant treatment. If they have severe symptoms of colonic obstruction and distension, bloating, then probably you should opt for diverting stoma. We alluded that maybe a stent. When you opt here for neoadjuvant treatment, 5% of those patients will have underway a diverting stoma, and then you can go for curative surgery. I think today we should avoid urgent rectal cancer resection. There is no place for a low Hartman. Maybe if we go for urgent resection, we should do a loop colostomy or a split colostomy. Neoadjuvant treatment seems safe for most of the patients. And again, the treatment should be individually tailored by a multidisciplinary approach. I thank you.
Thank you, André, for a very good, comprehensive lecture. I think you handled your patient very well. We would handle it exactly the same way. But in rectal cancer, you give neoadjuvant treatment to shrink or downsize the tumor. But what about colon cancer? What about sigmoid cancer or left-sided cancer? Would you treat that patient in the same way?
No. So for right colonic obstructions, then you immediately go for a right hemicolectomy. For an extensive right hemicolectomy. For patients who have a left-sided obstruction, if they have a sigmoid cancer and obstruction, then in most of the cancers, we do an on-table irrigation and decompression.
Because we have expanded this concept that you talked about also for the right-sided cancers and the left-sided cancers, if they are large and there's a suspicion of infiltrating the retinal structures. Defunction the patient, optimize the patient, stage the patient, come back for surgery later. I think this concept is also good for colon cancers, actually.
The problem is that you sometimes can have especially when you have, for example, an ascending colon cancer, you can get a blowout of the cecum. You cannot decompress it when you just do an ileostomy. In other patients, it's then difficult sometimes to judge where to position your colostomy. Again, for the left-sided, it can have an impact on how you ultimately will treat a patient. But again, it can be a very safe issue to put on a loop colostomy in the emergent setting. Yeah, I agree completely.
Questions from the floor? Yes?
If you have an abscess of the upper part of the rectum or the sigmoid, would you give radiochemotherapy?
I would discuss that with Professor Haustermans. Yeah.
We've done it. If you monitor your patient well and if you give antibiotics, it seems to be feasible, but you have to be careful, of course.
Can I just make a comment? Our radiation oncologists are very hesitant to radiate with the abscess, but we always drain these people because the abscesses are almost always retroperitoneal. You can drain the abscess and then give antibiotics, optimize the patient, and radiate later. And then when you operate, you excise the canal where you had the drain. So I think you should, in our practice, we always drain the abscesses first.
The problem, of course, is when the abscess is a necrotic cavity adjacent to the tumor, and then, of course, you can get spillage throughout the trajects of your drainage.
That's why you should resect it when you do the final operation. But I think in general, surgeons have been very optimistic in doing emergency resection of huge stenosing cancers. I think this is the wrong way. We see so often local recurrences because people have peeled tumors off ureters or bladders or spleen or bowel walls or whatever. So for many surgeons, they don't have the skills to do a good cancer resection in a huge tumor. So I think for many people it's better to defunction, come back when the patient is optimized with a good colorectal cancer surgeon. More questions?
I may raise a question. Coming back to this point, you have mentioned that you perform or that you like to perform neoadjuvant treatment in those patients, but a few of those patients need to stop neoadjuvant treatment and go to surgery. Is there any specific situation you avoid or you're afraid of after starting neoadjuvant treatment and then come to surgery during the neoadjuvant treatment?
Yeah, of course. You want to avoid in any patient that during the neoadjuvant treatment you have to stop that to put on a colostomy. So I guess if the patient, if the obstruction is just the fact that you cannot pass with the endoscope and with the flexible colonoscope, and the patient has few complaints, then by modification of the diet you probably will get through. But in most of the patients, of course, when you really have already bloating of the abdomen without any severe colonic distension yet, that's a difficult point. At that stage, you have to discuss with the radiotherapist and say, okay, are we going to give the patient a loop colostomy so that we are definitely out of the problem? If nothing happens just by the fact you make that loop colostomy, but again, it's not without any problems, also just making a colostomy. But that's the multidisciplinary consult. So again, from the beginning on, rather than when the patient comes in the emergency, it's not the surgeon who decides on spot, I'm going to give that patient a loop colostomy, I'm going to operate. That's already the patient you should discuss in combination, multidisciplinary. Where do we want to end? How do we have time to adequately stage the patient? Do we have time to postpone a little bit neoadjuvant treatment and give the patient a decent colostomy? And then you're out of trouble.
One more question.
Do you need an ileostomy after rectal cancer surgery? Because for us oncologists, it gets us a bit in trouble when performing chemotherapy because it increases toxicity due to diarrhea and hydroelectrolytic balance. So in my center, we prefer colostomy. So in the patient you had, it just keeps the colostomy and removes it when it finishes treatment.
I guess it's an excellent point you make. It's one of the problems of loop ileostomies is dehydration and the impact on renal function, especially in those patients where we do a exenterational surgery, where also a reconstruction of the bladder in those patients, we give them a loop transversostomy, loop colostomy. We still are giving, if we divert a colon pouch, we still give a loop ileostomy, but no, we have an adapted care plan that the patient get rehydrated. So we see a little bit less of those problems, but again, you're right, in some of those patients, we are urged to close the ileostomy due to dehydration. The problem sometimes is that if you have the vascular supply of your left colon that you use for the restoration depends on the middle colics. If you have there in that region your colostomy, the minor issue that happens and you interfere with those branches, you can lose the whole reconstruction. That's one of the reasons. Another reason is it's more simple to close a loop ileostomy than a loop colostomy, but you have a point, yeah.
Any more questions? If not, thank you very much, André, for a comprehensive, good lecture.